Hi everybody, good afternoon and welcome to our substance misuse webinar. This is part of our Be Healthy Webinar Series and today we have another great range of speakers with us who are going to talk through the content and help us through the webinar. So we have Tony Mercer, who's the Programme Manager for Drugs and Alcohol at Public Health England Midlands. We have Victoria Loveridge, Head of Services at Change, Grow, Live, and Caroline Hickey, team leader at Aquarius, with us as well. So just before we get onto the webinar, as per the others, I'll run through a bit of housekeeping and then a little overview of Be Healthy, and then we'll get onto the substance misuse content. So if we can have the next slide, please. Oh, and the one after maybe as well, thank you. So in terms of housekeeping, if you're not speaking, can you please keep your camera muted and your videos turned off? This just helps with our bandwidth. Also, if you have any VPNs on your laptop that you may be used to connect to a work network, such as NetMotion or Cisco, you can turn those off too. We found that helps with your connections as well. Throughout the webinar, even though we've just asked you to turn your video and your cameras off, we do encourage questions and chat amongst people. So if there's something you want to say or a question you want to ask, if you type in the chat box, I'll be picking those up throughout the webinar. We also have a question and answer sessions at the end, so it might be that we save them till then to pull them in, but they will be monitored throughout. So if you have something in mind, just pop it in the chat box. Equally, we understand that not everybody might want to ask a question in front of everybody else. So if there is something you want to know and you'd like an answer to, you can email us at healthybrum@birmingham.gov.uk, and we will make sure we get back to you with a question and involve whoever we need in that response. And then lastly, on the housekeeping front, as we've already said, today's webinar will be recorded and uploaded onto our YouTube, the Healthy Brum YouTube channel, and linked from the same place on the Birmingham City Council website as the bookings for the webinars. So people can use the recording as a resource. So moving on to the Be Healthy overview. So Be Healthy is our campaign that we're doing. It's a practical set of resources that will hopefully help leaders and professionals that work with communities to have some positive messaging and some support and some good tools that they can use with their communities to reduce the risk of them becoming seriously ill from COVID-19. There's alongside the webinars, we have a 4-page handout which has a checklist to a healthier you and some COVID safety messaging. This is translated into 20 languages that we can download from our website, which you can use with your communities. And they cover all of the topics that we're covering in the webinars. So the webinars give more details on how you can change behaviours and tips and tools that might help you for the things that are identified in the checklist. So far on the webinar series, we've covered the COVID safe ones, so about hand washing, testing, what to do when you're self-isolating, and some tips to help with self-isolation. We've also run through the long-term conditions part of it, so looked at some of the long-term conditions that most linked to COVID. And now we've started on the things that if you did more of, they would benefit your health, and maybe other things that you might want to think about doing less of, again, to improve your health. So that's Be Healthy in a nutshell. Again, any questions that you have on that or any more information, you can contact us directly or drop them in the chat box. So I think it's time to move on to the next slide and onto our first speaker for today. So I'm going to hand over to Tony, who's going to give us an overview of COVID, drugs and alcohol and what's been happening for the last 6 months. So Tony, over to you. Thank you very much.
Okay, thank you, Stacey, and thanks to you and Natalie for the invitation to come and talk a little bit about drugs and alcohol services. Could we go on to the next slide, please? I'm going to try and set a little bit of context. So I'm going to say a little bit about what some of the challenges for drugs and alcohol services have been over the last 6 months, say a little bit about how those challenges have been met. Trying to focus on Birmingham, but my role is regional, so maybe bring in a little bit from across the region. And then a little bit about where we are now, some of the learning that we've gathered from the last few months. And the main thing I want to talk about is screening, brief interventions and referral. So how can you as workers out in the community who engage with people every day who have problems with drugs and alcohol, get them to the right place that they need to be to get the help that they need. Okay, next slide, please. I feel like Boris Johnson at one of his press briefings saying that. Okay, the challenges we've faced over the last couple of months. As soon as the pandemic started, we went into lockdown. The World Health Organization was very, very clear that drugs and alcohol services need to stay open. Other parts of the health system closed down, but we had this sort of really crystal clear leadership that drugs and alcohol services were more important than ever. And there were a number of reasons for that. Firstly, people turn into alcohol and drugs in a way that they hadn't used them before. Obviously, lots of people drink and use drugs recreationally, but with the pressures of lockdown, a lot of people's mental health took a battering, and there was the risk that people would start using in a way that was dangerous. A lot of the people already in drugs and alcohol treatment who maybe are dependent with that increased risk of withdrawal and overdose and a whole range of health complications like seizures and so on. A lot of long-term drug users and drinkers, because of their physical health condition, were obviously more susceptible to infection with COVID-19 and to a lot of the health problems associated with it. We were very sorry, my phone just went off. We were very concerned about the impact that lockdown could have on drugs markets. We'd never seen anything like this before in the UK. We were worried that people might start breaking into pharmacies. We were worried that fentanyl might get into the local heroin markets and so on. We were really going into the unknown. There was this amazing government campaign to get rough sleepers into safe accommodation, and that posed some challenges for drugs and alcohol services. There was the risks of diversion of particularly methadone. So people who might be going to the pharmacy daily or every couple of days to pick up their methadone, often were given several days or up to a week's worth to take home with them. There was always the risk that that would end up being sold and used by people that it shouldn't be used by. There was the issue of PPE for staff as well and staff resources. We found out recently that actually staff sickness over the last 6 months was far, far less than it has been over the previous 6 months. So great credit to the staff and their dedication and commitment. The government did make additional funding available to local authorities to deal with the pandemic. None of that funding found its way into drugs and alcohol services. Okay, next slide, please. So how did services across the region and in Birmingham meet those challenges? Because of the issue I've just mentioned about moving away from daily supervised consumption, they had to carry out individual risk assessments of all their clients. Medicine safety boxes were provided with no extra funding for people who had children in the house. So these are small lockable boxes to lock away supplies of methadone and other controlled drugs that people were prescribed. A lot of services like CGL in Birmingham provided mobile phones for vulnerable clients so that they could stay in touch with the service. There was a lot of great communication between different professionals. I think often professionals that hadn't spoken very much before. And obviously that was linked with the use of online platforms, and online platforms such as Zoom were actually used for interventions with clients, group work and so on. A lot of the mutual aid groups in Birmingham moved online immediately. Our national team were regularly producing updated guidance. I think there was a feeling in the field that often that guidance wasn't quick enough, but there was a big sort of bottleneck at number 10. People from all different kind of fields were wanting their guidance signed off and be published. But I know drugs and alcohol workers were dealing with a lot of critical issues on the front line. For example, could community groups buy alcohol for somebody that was alcohol dependent and was at risk of seizures and so on? In the last couple of months, we've seen a significant increase in alcohol community detoxes, and particularly here in Birmingham. We haven't seen any data that suggests that there's been a significant increase in drug-related deaths over the last 6 months. And we've actually seen quite a big increase in new people coming into treatment for opiates. Some of that is linked with the emergency accommodation, and workers were able to engage with people there who maybe had never been in treatment before or had been in and dropped out. On the negative side, across the region, we know that some young people have become disengaged. I'm not too sure what the situation is in Birmingham, but in other areas across the region, I think some workers struggle to keep some young people engaged over the last 6 months. Okay, next slide, please. So where are we now? So services have been for the last 2 months actually trying to restore face-to-face interventions. One of the problems they're facing now, of course, is local restrictions, and that they're different in different areas. Birmingham is being impacted by that, but worse, it is safe to restore face-to-face interventions. That is now happening. There's now a range of blended offers available for people in drugs and alcohol treatment, so a mixture of digital and face-to-face. And I think it needs emphasising that digital interventions aren't a substitute for face-to-face interventions. And we don't want to get into the scenario where commissioners say, well, they worked well for the last 6 months and they're cheaper, but they can be a beneficial supplement to face-to-face supplements. So I think the future is more kind of blended service offers, but face-to-face interventions are still the kind of main bread and butter of drugs and alcohol services where they can be delivered safely. What PHE in the Midlands have been doing is facilitating a structured debrief process, working with the commissioners across the region. So we're trying to capture all of the good practice that's emerged over the last 6 months. And as part of that process, they're going to be making recommendations, and we're going to get them in front of directors of public health across the region. One thing that's really stuck out for me, which is going to stick hopefully, is improved partnership working between drugs and alcohol services and other partners. And I think today it is part of that process as well. Okay, next slide, please. What I wanted to talk about mostly was how non-drugs and alcohol specialists can screen people that they work with for problematic use, and deliver brief interventions and refer people into specialist services that need that. And for a while, we've had a really good alcohol screening tool, but we've had various tools for drug services. And I think it's fair to say that as a field, we haven't equipped non-specialist workers to do that as effectively as sometimes they've wanted to. Now, I was away on holiday last week, and when I got back, I found out that PHE had published something called a cyst light screening tool. And I had a look at it on Sunday, and it's absolutely brilliant. It's a whole range of resources to equip people working in community groups and other health and social care settings to enable them to effectively screen people that they work with, deliver brief interventions, and get people into specialist services that need it. I put a link at the bottom of the page, and hopefully that will work when these screens when these slides go online. And I'd really recommend having a look at all the resources on that web page. I think you've got to email and ask permission to use some of the screening tools, but that literally takes a couple of seconds to do that. Okay, and last slide, please. So finally, I think I'd like to emphasize that drugs and alcohol services are still here. They never went away. Some of the interventions were delivered in a different way, but they're still here, they're still open, and there's actually a lot of positive learning from the last 6 months that they're now in the process of applying. Please have a look at the Assist Light screening tools. And if you work for an organisation and you're coming across a lot of people who've got drugs and alcohol problems, please talk to CGL. Their staff might be able to come in and deliver some kind of training for your staff to make them more confident and equip them to deliver those screening and brief interventions, and maybe establish some more formal pathways into specialist services. So I'm going to leave it there, but I'll be around for some questions later. Thanks.
That's brilliant. Thank you, Tony. No, such a good overview of the difference during COVID, and it's really good to hear how the services have evolved and how they're still evolving, and be interesting to see where they end up with the blended services as you were referring to them. And I also think the Assist tool that you've just finished talking about will be so useful to lots of people here and lots of people that will listen to the webinar. So yeah, thank you very much. And Tony, as he said, will be with us, so he will pick up questions at the end, but keep them in the chat, keep dropping things in as I can see they're coming in. Thank you. Okay, moving on to the next presentation, Natalie, please.
No problem. Next up, we've got Victoria Loveridge from CGL.
Thank you, and welcome, Victoria.
Hi there. Yeah, so actually it's Vicky Loveridge. So Victoria sounds so formal, doesn't it? Vicky Loveridge, Head of Services for Change, Grow, Live. And I'll be giving a general overview about the service. I'll probably end up speaking really quickly because I know time is really limited. And then we've got Dr. Ramegowda, our lead regional consultant, who will talk more about the clinical interventions through COVID. And actually hearing Tony speak then, some of the presentation actually echoes what Tony has mentioned, which I think reflects really good communication that we've had locally and nationally between CGL and public health. Can we go to the next slide, or the one after that, I think, actually? Thank you. Thank you. So for those that don't know us, CGL has been providing services in Birmingham for anyone aged over 18 experiencing drug and alcohol problems since 2015. And we currently have 5,760 individuals accessing support. For those that remember or know us, we were initially based at Scarlet House in the city centre and would work out in various community settings across the city. And during the initial years, we listened to both service users and staff about how they felt about Scarlet House and being based in the city and that model. And as a result, we adjusted our model, moving out into community areas. This has resulted in greater engagement for service users and a much better connection for us to our local communities. Can we move on to the next slide, please? So as well as our core services in the 4 hubs on the previous slide, we also have 4 specialist teams. With the finite resources we have as a service, we are really strongly committed to ensuring these teams continue to provide a service to some of the most complex and marginalised of our service user groups. The teams have developed some excellent working relationships with partner agencies across the city. And collectively, they all work incredibly hard to support our service users to change their lives for the better. Can we have the next slide, please? So how to access the services. So individuals can self-refer or be referred by partner agencies. Referrals can be made online via the website or by telephone. And individuals can drop into the hubs, but during our current, during the current time through COVID, we're asking that where possible, this is avoided. Of course, if someone does turn up, we will see them. Can we move on to the next slide? Sorry, there's so many slides. Individuals will be contacted by telephone to complete a triage, and based on that outcome, will be booked into the relevant part of our treatment pathway. So our model is based on 5 phases, starting with phase 1, which is around brief interventions, where we would offer advice, information, signposting, access to needle exchange. Some people access needle exchange and don't feel ready to access structured support. Through to phase 2, which is about group program for non-dependent alcohol and low-level drug users. Through to phase 3, which is where we would provide clinical interventions for opiate and dependent alcohol users with one-to-one and group support, and very much about person-centred support planning. Phase 4 is our inpatient detox facility at Park House, and finally phase 5 is aftercare. So throughout an individual's journey with us, we work with them to identify areas of their life that would really benefit from having wraparound services to improve their outcomes, and that could be health, mental health, employment, housing, etc. And this will be done in conjunction around supporting behaviour change, looking at increasing self-esteem, and generally connecting to the community. Could I have the next slide, please? So our partners, the partners really form a key part of service model, which includes pharmacists across Birmingham. And we currently work with 400 across the city. We work in partnership with shared care. So we work with in partnership with the GPs. We currently have 46 GP surgeries that we work with, where we work with the least complex service users with opiate dependency. And then I've listed the 4 partners: Changes UK, Datus, Intuitive Thinking Skills, and Hickey. And these really bring additional mix of skills and expertise to support and enrich the service delivery, from aftercare, peer-led support, mutual aid and advocacy, through to bespoke accredited courses around behavioural change, employment, domestic abuse, and then through to engaging with diverse Black and minority ethnic groups. So have the next page, please. So our group offer. During COVID, we paused face-to-face group work, but continued to offer the main structured groups virtually via Zoom, which was a challenge to begin with, but I think it was everywhere. But in consultation with service users and peer mentors, we've really seen this as an opportunity to review and change our group offer, and in November plan to roll out a new format of structured group interventions with a variety of almost a pick and mix modular group offer that we intend to grow over time. And these groups will be run by peer mentors and volunteers. So that the recovery support groups will be available to services at any stage of their treatment journey with us. So it won't be when they're much later on in their journey, but we see this as happening from day one. And groups like the LGBTQ+ are not there to replace those already on offer in Birmingham, but provide an opportunity for individuals to connect with people in a safe space with similar experiences, to explore the impact substance misuse has on them. And our intention post-COVID is to offer a mix of in-the-room and virtual groups using Zoom suites, as we really believe this will help us to engage and connect with more people. Next slide, please. So promoting visible recovery is so important for Change, Grow, Live. And our peer mentors in the service are really able to engage others through those shared experiences and can really provide hope and actually be the catalyst for change for some people. As with volunteers, peer mentors receive training and regular supervision to help develop the skills. And what's brilliant is that several have gone on to gain employment within the CGL and also externally. It's really important that we continue to ask service users if what we're doing is working or could be done differently. We are here to serve them and to make a difference, and service user involvement is integral to improving the quality of our service. So we consult with service users regularly through various formats and forms such as focus groups. Next slide, please. So the next two slides really are about what's happened through COVID. And at the start of the pandemic, we quickly initiated a business continuity plan with the overall aim of continuing to provide a service while ensuring the safety of service users and staff. And huge changes were made really very quickly. And I genuinely believe that what was achieved was incredible. And the response from staff, volunteers, peer mentors, our partners in achieving it was amazing. Throughout the pandemic, our hubs have remained open. The buildings have been risk assessed and all our staff have had individual risk assessments too. Dr. Ramegowda will talk more about some of the changes, but in keeping service users safe and reducing the impact on pharmacists, we reduced the collection regime of medication for service users, meaning they had to go to the pharmacy less often. And this meant hand delivering 2,700 scripts to approximately 400 pharmacists over 2 days, which was absolutely phenomenal. We also delivered hundreds of naloxone kits, and for those that don't know, that temporarily reversed the effects of an opioid overdose and saved hundreds of lives. And safe storage boxes to service users homes and pharmacies. Contact, as Tony said, has been predominantly virtual by telephone or Zoom, but people have been coming to the hubs, predominantly for drug tests, and now more so for ECGs and also blood tests. And to maintain contact, as Tony did mention, we've provided mobile phones to service users, particularly the homeless community. And I think it's really important to note that since April, we've seen 2,000 individuals access the service for structured support, which is in itself absolutely fantastic. So if you can go to the next slide after next, I think we might have covered most of that. So then, yeah, the next one, please. Thank you. So throughout the pandemic, we've been gaining feedback from service users about how they have felt supported. And this has been really positive. Service users have said they felt supported to remain safe and felt updated. Individuals on scripts said they felt empowered and more in control of the treatment through collecting the medication less frequently. And some have said they prefer virtual contact, whilst others have said they miss face-to-face contact. And some don't have the technology to access virtual groups. We will continue to learn from the feedback, and we will continue to flex our service delivery in line with government guidance and take forward the things that really have worked well post-COVID. I think what is really clear from the feedback we've had so far is that increasing choice in ways to engage with the service is really important for service users. So I'm going to hand over to Dr. Ramegowda now. Thank you.
Thanks, Vicky. Can I have the next slide, please? Yeah, okay. Afternoon, everybody. I'm Adi Ramegowda. I'm the Regional Lead Consultant for CGL in West Midlands. I literally have got 5 or 6 minutes to talk about our community clinical services provision and our inpatient unit during COVID. So I'll crack on, and I will be available for any questions during Q&A. I'll give an overview on service provision during the peak of COVID, and I would have liked to say post-COVID, but now unfortunately it looks more like a pre-second wave or a second peak. There will be some overlap on what Tony and Vicky have already said, so my apologies for that. Next slide, please. I'll start with the opiate services provision during the peak of lockdown around March or April this year. Following the outbreak of the pandemic and the lockdown announcement, our main priority was focused around staff and service user safety. We had to adapt quite quickly and find innovative ways of remote working. Thankfully, our IT systems were well equipped for a quick transition of service delivery on a virtual platform. Most of our national meetings within CGL had a sizable number of people attending remotely from before the lockdown. So, which did help logistically. It made it easier for us to move to a virtual platform. Our immediate next steps were to quickly develop a COVID-specific medication-assisted treatment guidance and processes to support remote working in a safe and effective manner, and get people into treatment quickly and retain them in treatment. At the peak of the pandemic, we were getting people in within 24 hours of referral, and it'll show. I'll show the numbers later on, and it'll reflect the increase in numbers. All our reviews and consultations moved to either telephone or video reviews. And incidentally, the positive outcome of that was that the approach of telephone consultation reduced our DNA rates quite significantly, reduced by up to 30%, in fact. We also needed to act swiftly and reduce the footfall at pharmacies, and a well thought out and measured decision was taken to move majority of our suitable clients to 2 weekly collection of prescription, following completion of individualized risk assessments, which we call as reviewers dispensing regime, which is RDR. And we developed a COVID-specific risk mitigation tool, which I just mentioned, RDR, with service user involvement at the heart of it. Any decisions made with regards to prescription change, we involved service user in that decision-making process. To complement the above decision, we ensured, like Vicky said earlier, that there was a wide distribution of safe storage boxes and take-home naloxone. In some cases where we thought, okay, it appears to be a bit of a higher risk, we even provided double and triple doses of take-home naloxone. We had to temporarily suspend drug screening. Obviously, clients were not coming into the hub, so we had to suspend drug screening and opiate detoxification. Suspending drug screening meant methadone was more of a risky option to start as an opiate substitute treatment, and buprenorphine became essentially our go-to drug. Throughout the pandemic, all our community hubs have remained open, albeit with limited access. But if service users wanted to come in, it was open and there was access. Next slide, please. Following on from the peak, and with the easing of restrictions towards the end of June, we have continued to remain open with increased footfall as we have restarted drug testing, ECG, taking bloods for alcohol detoxes. And we have put in place social distancing measures within our hubs. We have risk assessed all our hubs, like Vicky mentioned earlier, and the PPE provision has improved significantly and is now near adequate. Majority of our clinical consultations are still happening remotely unless there is an absolute need for face-to-face consultations. Where drug testing is needed, we have now introduced fingerprint testing to complement existing urine drug screen provision, which has been quite useful. Now we are also able to provide options of both methadone and buprenorphine for new starts because drug testing is back in place. Community opiate detoxes is now recommenced and is well supported. And equally, psychosocial interventions, mutual aid, relapse prevention groups are all happening virtually, mostly on Zoom and some on Teams platform. And majority of our clients still remain on the least restrictive collection regime. And we have put in place periodic reviews of any associated risks. A small cohort of high-risk clients and people who newly come into treatment currently remain on daily supervised consumption. But majority of them, they're on weekly or twice a week collection. Next slide, please. Okay, moving on to alcohol service provision. During the initial period of the lockdown, we had to briefly suspend community alcohol detoxes. until we figured out how we were going to proceed. We did continue to take in referrals, and the clients, the new referrals and the existing caseload was supported by our nursing team, by recovery coordinators with regular contacts ranging from weekly contact to monthly contact. And harm reduction and drink down plans was the crux of the support. We had a COVID-specific alcohol treatment plan in place in doubly quick time, as the number of referrals kept increasing, and the lockdown itself, as you all know, had a direct impact on increased alcohol consumption among general population. By the end of April, we had established home detox provision, moving away from our usual ambulatory detox in the hubs. And we had a weekly alcohol-specific MDT meeting in place, involving the recovery coordinator, nurses, safeguarding lead, and the consultant. In those meetings, the cases were extensively discussed and management plans agreed, with enhanced support in place to ensure safe and effective home detox provision. Next slide, please. Okay, we now continue to provide home detoxes, which is now embedded into our service, which is another good thing which has come out of this whole dire situation. And assessments and support remain remote via video chat and a twice-a-day contact from our nursing team, specifically during the actual detox period. Since April, we have now completed over 100 home detoxes, and the support is ongoing with referral numbers still quite high. So the numbers keep increasing, and I've never seen these kind of numbers come into service in my experience in Birmingham for the past 5 years. We support our clients post-detox via remote psychosocial interventions on the Zoom platform. And like Vicky said, we are looking at other innovative ways of psychosocial interventions virtually delivered. And we, of course, relapse prevention medications. Next slide, please. Okay, moving on to our inpatient service provision. Like majority of other inpatient units in the sector, we had to temporarily suspend our admissions to Park House. Although COVID did play a part of that decision-making, the temporary closure of the toxicology unit at City Hospital was more of a reason for us to temporarily suspend admissions. Toxicology unit is our feeding unit from Park House for any clients acutely deteriorating during detox and needing a medical bed. So we essentially transfer them to toxicology, and we have a working understanding with toxicology unit. Following the temporary closure of Park House, clients who were due for admission or clients who were on the waiting list were provided with ongoing support by the Park House nursing team, with twice weekly contact established and a support plan in place. And we reviewed the support plan and the contact regularly during weekly virtual ward rounds. All these clients were regularly discussed in virtual weekly ward rounds. Next slide, please. In mid-August, we started taking in admissions again. Our buildings were renovated to ensure that we were compliant with social distancing guidelines. We updated our business continuation plan and ensured the unit was safe against COVID infection, and also built in resilience in the event of any COVID outbreak within the unit. We stress tested our business continuation plan by limiting our initial admission to about 6, and now we increased our bed capacity to around 10. So far, there has been no serious incidents other than brief periods of patient needing isolation, symptomatic clients needing isolation, whilst awaiting COVID test results. We are now looking at further increasing the numbers to full capacity in the coming weeks, depending, of course, on the trajectory of cases and the local lockdown arrangements across the country. We do get clients coming in, not just from Birmingham, from all across the country where CGL provides services. Next slide, please. Finally, just to give you a perspective on the numbers, around caseload numbers, the numbers before March as compared to our current caseload. Our opiate treatment caseload has increased to 4,000 clients, up by around 650 pre-March. So 650, the number 650 is in itself a full caseload number of some of our services in the country. and alcohol caseload has increased by 225, and the overall caseload now stands at 5760. It is good that so many service users are accessing treatment and new clients are coming in, and we are retaining patients in treatment. It is fantastic to see that, but of course we need to be mindful of the resource we have available in hand as well. That's my rapid fire 5 minutes done. And thank you very much for listening. And I'll be available for during Q&A if there are any questions. Thank you.
Thank you both. Thank you very much for that. Again, loads and loads of really good information there. And I can see that whilst you've both been talking, there's lots of chat going on in the chat box as well, which is great. And we'll get onto that shortly. So now just time to hand over to our third speaker. So I'm going to introduce you to Caroline from Aquarius. I think she's going to try, she has pre-recorded her her presentation. She's going to try and play it from the recording. So over to Caroline, and let's see whether we can make that work. Thank you.
Thank you.
I should keep talking to fill the gap, shouldn't I? It'll be with us shortly. I'm sure we did have a practice of this beforehand and we got it working, but if not, she is going to speak live. I can hear it in the background, I think, but not see it.
Okay, I'm sharing it now, so you should be able to see this. Can everyone see that?
Not yet. I can see the folder that's open.
Okay. Bear with me.
It's okay, don't worry. Whilst Caroline's starting to make that work, I'm just thinking in preparation for the next bit, and there's loads of really good questions, observations, discussion points in the chat. So I think what we'll try and do today is bring people in to actually ask questions. So if there's somebody who wants to start that off, then just put your name in and I can bring you in first when we get to it. It looks like we might be about to start the playback. Again, I think we can hear it but not see it, maybe.
Okay, I'm gonna give up with this because otherwise I'm wasting my precious time by trying to. I'm just gonna talk through the services that we support. If you don't mind, I've got a written document that I need to just to refer to, just to make sure that I don't miss anything. So I'll get that ready and then I'll start talking. It'll be about 5-6 minutes if that's okay. I think we've got time for that.
Absolutely great. Thank you, Caroline.
Is that okay? So I'll just get that ready and then
that's fine. And we'll share the video clip afterwards as well, because we can upload that too for you all to watch.
Fab, thank you. So my the information that I'm going to talk about is it's just an overview of the services that we offer, and I have got some more information about what we've done during the pandemic. But if anyone's got any specific questions about that, like how we've been operating, then I'm happy to answer those. But this is just a general overview of what our services offer to young people and their families in Birmingham. So I'm presuming you can all see me. Is that right? You can all see me. You're not looking at my file opening thing or anything.
We can see you. It's absolutely fine.
Right. Okay. So hello, everybody. My name's Caroline. I'm team leader here at Aquarius Young People Service in Birmingham. So I'm here today to tell you about our service and the ways in which we work to support young people and their families. So Aquarius does operate within the Midlands region. We've got services in Wolverhampton, Oxford, Bedford, Northampton, Derby and Telford. But today I'll be talking specifically about Birmingham Young People Service. And if you want to look at any more information about the other services we offer, we've got a website, which is aquarius.org.uk. So the Birmingham Young People Service is made up of a team of staff, which include complex needs practitioners, family workers and support staff, and these are working roles to support young people and their families. We work to support young people between the ages of 10 and 18, and young people are referred to our service with a variety of different needs, and we receive referrals from lots of different places, including schools, care homes, GPs, health clinics and other and sort of CAS, Children's Advice and Support Service in Birmingham. So the role of the complex needs practitioner is to support young people who are affected by substance misuse or affected by someone else's substance use. And then alongside that, we work to support young people with a variety of the complex needs, which might include mental health, gang affiliation or negative peer groups, child sexual exploitation, criminal exploitation, trauma, bereavement and housing need. So many of the people that come to our service have used or are currently using a combination of harmful substances, and it's the work of it's the role of our workers to educate and advise young people on the dangers of harms and related to substance use, but to work with them to create sort of positive change and coping strategies. So we're able to work with young people around the dangers of using all sorts of different substances. Mainly we see presentations for cannabis and alcohol, but recently we have seen an increase in things like ecstasy and cocaine, and also what are called MPS, which are novel psychoactive substances. They used to be called legal highs, but we still do get presentations from young people using those substances. The other thing that we've seen kind of I haven't personally seen much of this over the lockdown situation, but I know in the last 12 months we've seen quite a lot of what we call volatile substance use. So that's young people using aerosols, gases and glue. So the team have had specialist training on how to offer interventions around the dangers of using these substances, because that's one of the things that we can't offer any harm reduction advice around. Normally people would come to service and we'd say, well, if you're going to use this substance, this is how to do it in a more safe way. There's absolutely no harm reduction advice available for volatile substances. So if someone comes to the service saying that they're using aerosols, we don't say, oh, well, you could use aerosols in a more safe way, because there isn't a safe way. So that's one of the things that we've done recently. So we work to support young people and we have young person-centred care plans, which the young person's involved in, and we support their treatment with other services, which includes, we work very closely with Forward Thinking Birmingham, also known as FTB, and that's to support with young people's mental health. So we get a lot of presentations of young people with mental health need. And within our service, we've got the opportunity to be assessed and work with a consultant psychiatrist and nursing team, and that's for diagnosis, medication if that's needed, and ongoing support. We work with Bernardo's in partnership to support young people who are affected by CSE, and we've got a seconded worker with us from Bernardo's to support young people who are affected by CSE and substance misuse. That's quite a specialist role. And we work with St Basil's to support young people who've got housing need or problems, and we link closely with that service. So some of the young people that we work with are affected by someone else's substance use, and this is where our Choices service works to support young people with safety planning, building resilience and engaging in supportive interventions so their voice can be heard. And we also work in partnership with the Youth Offending Service in Birmingham and support young people who are subject to proceedings with substance-related offences. So we've got practitioners in each of the youth offending teams across Birmingham. And the interventions we undertake with these young people include advice, education, harm reduction and support. And we work very closely with the youth offending team workers to support young people and educate them from harm and protect them from harm. So the complex needs practitioners can work with young people over several sessions, and we can tailor these depending on what the support is needed. We also work very closely with CAS, which is the Children's Advice and Support Service in Birmingham. We've got lots of safeguarding things that come into our service, so we need advice and support from them and to be interlinked to the work that they do. Some of the young people that we work with are subject to care proceedings or orders, and we've got a specialist part of our service which supports these young people with specific interventions. So that's our service there is called Aquarius Cares. So that service works directly with young people who've got CP plans, or they're at child in need status, or they're having family support, and that can be to do with parental substance use, parental mental health or domestic abuse. We've recently just started up a family service that's made up of 2 practitioners, and they work with adults who are affected by someone else's substance use. So our work there is based around the 5-step family model and in supporting family members along with other members of the family. We've got something called Forward Carers, so that aims to support young people affected by someone else's substance use, and that links really closely with the choices work because the interventions there are quite similar. So in addition to the interventions that are offered there, we've recently been involved in like delivering meal kits to families who need help. So this part of the survey, I did some yesterday actually. So in partnership with our social enterprise Evolve, we weigh out all the ingredients, they're all fresh, measure them out and pack them up nicely, give them a recipe card to make a 3-course meal. So yesterday they had a 3-course meal which was all ready to go and they just have to cook it. The idea of that is that it encourages family members to work together to create a meal and spend time together during meal times. It's kind of like quite a good activity to encourage like communication and time together. We've got a garden project at our head office, which is managed by a practitioner, and this is called the Grow Project. So that project aims to support young people in alternative uses of time and to encourage and promote well-being and self-esteem. I'm a bit mindful here that I'm running out of time. I'm nearly finished, so I'm not trying to sort of use up more time than I'm allowed. But the Grow Project is it helps to people get involved in garden activities such as maintenance and planting and growing produce, which then can be turned into like healthy meals and to learn more about nutrition and well-being. We've supported quite a lot of school groups to come and use the facilities, and that's been really, really, really good. And we've recently undertaken an initiative around rough sleepers and in supporting young people with housing needs, including those who might be roofless. So that aims to support young people into stable, kind of maintainable accommodation and to support them with substance use at the same time. So that's quite a new project that's working really well. And just to say that in the recent sort of changes to all our working practices during the pandemic, we've been able to continue offering our support service, and we've done this by offering kind of telephone and virtual appointments. More recently, we've been doing what we call walk and talk appointments. That's where it's safe and appropriate. We go out for a walk with a young person at a social distance. And we offer like interventions on Zoom and everything as well. And we're able to go doorstep visits, because as you say, like young people, kind of there's nothing that can replace a one-to-one intervention. It's just not the same on the phone, or but where it's been possible to do it, we have been offering the face-to-face support services. So I know I've given you an awful lot of information there in quite a short spot. I'm aware that I'm speaking really quickly, so if anyone's got any questions, I'm more than happy to answer those for you in a minute if there's time. Thank you.
Thank you very much, Caroline. That's great. And I appreciate how hard that is just to come in and do that when you thought you were all sorted with a recording.
Okay, it's fine.
So thank you very much. So there've been lots of questions coming in the chat. So I just wonder if it's worth everybody who's been speaking, so all the speakers can come back in, turn your cameras on and get ready to see if there's anything you can answer. That would be great. Thank you. So hi everybody. I think there's an observation here from Ricky. So Tony's, oh hello, my screen's just jumped all over the place. Tony mentioned, he says that Tony mentioned young people are disengaging. So I think he's thinking is what are Aquarius doing to help and support young people engagement? I don't know if Ricky...
I'll have to caveat that with saying I don't know specifically if that's the case in Birmingham, but this was from feedback from commissioners across all of West and East Midlands, and quite a lot of areas did say that this was an issue. Young people like face-to-face contact and stuff, and some of them now are doing what they call walk and talk sessions, because some of them are delivering services from partner organisations and they're still closed. So I don't know if this is an issue or to what extent in Birmingham, but it's definitely something that's come up in a lot of other areas.
Okay, that's great. Thank you. The chat box is moving quicker than I can read it at the moment. Lots of people typing things. So I think there's some questions around support for young people around glue and recreational drugs, and it looks like CGL are linking signposting Aquarius for that. I don't know, Sian, if you want to come in and say anything about that. You've written quite a lot in the checkbox. Thanks, Sian.
Yeah, sorry guys, it was just an offer. I know that we're doing some stuff nationally, so don't mind linking Caroline in with our national.
That'd be brilliant. I think because I was speaking so quickly, a lot of the things I said might have been a bit jumbled. So what I meant just by that is that I tell the practitioners not to give harm reduction advice for like aerosols. So like, you know, if a young person comes in and says, I've been doing this, we don't say, all right then, well, if you're gonna, you know, there is stuff you can spray it on a cloth, for instance. It's less dangerous than spraying it directly into your mouth. But I say that we just tell them to stop because of the risk of death. But I'd be really, shall I email you?
Yeah, drop me an email, Caroline.
Thank you, that would be brilliant.
Raj Umbi, who's our national YP lead, is kind of well versed with this, as well as the whole party scene, the illegal party
scene.
And
no, yeah, that's
they've been
so helpful.
Happy. He's been leading a massive research project during COVID. And if I can link you up with him, that if he can help you out in any way, I'm not saying that he can, but I'm more than happy to connect you both.
Thank you very much. That would be brilliant.
You're welcome. If you just drop me an email.
I will. That's
great. Thank you. Part of this is so valuable if we can make the links for people to carry on working to benefit people in Birmingham. So that's great. Ricky, do you want to come in? You've just said the hand function's not working and you'd like to raise a question. Do you want to come in and speak live?
Yeah, that if possible, yeah. In the cell work that I've been doing in public health is around comms and communities. And very early on in our work, especially when disseminating national guidance and trying to localize it from Public Health England, we came up with a problem around translations and engaging with BME communities, especially. A lot of the guidance coming out was just in English only. How have you guys, in terms of the panel and obviously with Tony, addressing the fact of to the services that you're doing to have those translations with the latest information from your service to those communities in the city, considering that, you know, numerous times they've been mentioned to be some of the most vulnerable to COVID?
Do you want me to take that first then? I think the whole thing about guidance in COVID was a problem anyway. And I think in my role, I was kind of caught in the middle between the national team and people working at the front line in local areas were saying the guidance wasn't coming out quick enough anyway. I think the point you're raising, Ricky, puts a whole other level of complexity on top of it. Some areas have been tackling COVID, actually working with and through the communities rather than kind of doing things to the communities. I know Lewisham have been doing this brilliantly, where they've got community members in, trained them up, and then they've done the work like translation and passing messages on throughout the community and stuff like that. I think the only way to tackle this properly is by professionals working authentically with community groups. It's not something professionals can do on their own. I know there's all the kind of legislative requirements and things like that, but that would kind of hold things up again. I think it's got to be in partnership with communities, not just doing things to them. I know, for example, in Birmingham, there's a Polish community group, and they took it upon themselves to start translating guidance and disseminating that out to community members. So I'm not trying to get professionals off the hook, but there are other people who can do that stuff much better than we can.
If I can add to that, Stacey, Sean probably is in a better position to come in here, Sean and Vicky. But CGL, we discussed in our senior leadership team meetings about language problem, about how we are reaching out to ethnic groups, minority ethnic groups. And the leaflets we were giving, a majority of it was in English, and it had come up. And Sean, I remember we discussed about leaflets going out in different languages. If you want to come in here and just elaborate on that.
Yeah, no, that's fine. They're all done. They're all prepped. It's been a recognition that there is potentially a gap, specifically within the rough sleeping community. I can only speak for Birmingham. In terms of the need for bilingual complex case workers, which is a project that we're kind of currently working on, specifically within the rough sleeping community. It seems to be Birmingham specific, but CGL as an organisation, yes, definitely, it's been a recognition that literature and entry into services and services need to be recognising that not everybody, that the first language isn't English, and also cultural stuff as well, around ensuring that we've got the right person in the right place at the right time to be able to engage those cohorts. So we've set up a BME forum, or a Black Lives Matters working group as well within Birmingham, to be able to service those people that best need our services. So that's kind of where we are. Vic, I don't know if you want to add anything else to that.
I mean, I guess some of the key messages went out by Hickey, didn't they? We really tapped into them in terms of their reach. And, you know, we use translation services, but that is on an individual basis with a service user when we're having those one-to-one contacts. So that is slightly different. But yeah, like Sean said, and Adi, we recognise it as an issue, and we are working on it.
So the bit which what I'm saying is in terms of understanding what you guys are doing, and Tony talked about the Polish community. We commissioned that service. We commissioned 8 organisations alongside another 30 organisations coming through. So my offer is basically saying that I can get together the community groups that we've got, provide an audience for you guys, and then the translation services or any key messages that you need to get out in those languages, we can connect you with those guys, because they've already got the established links in there. So with the Chinese Community Centre is another one who we commission with, the Pakistani Kashmiri community, the Roma migrant community, traveling community, and so these are the LGBT community. We've commissioned these specifically to help translate some of the COVID guidance out there, but more importantly, some of the referral services that are needed in the city. This is exactly the kind of things that we need to give to them in terms of content.
I couldn't agree more, Ricky. In fact, we have a national inclusion and diversity lead, Sean Kennedy, isn't it? Vic and Sean.
Sean Kennedy. Yeah.
He is doing a lot of work around this, so it'll be really good if. Ricky has done quite a bit in Birmingham with leaflets and stuff. So, there's a learning from both sides, I think.
No, that sounds really positive. Thank you, everybody. It sounds like something that we can take away to further make sure that all this messaging and the support available, and there's clearly lots, but it is getting to the communities that need it in a way that they can understand and use it, which I think is really, really important at the moment. So I think that's all in the questions. There's just a couple of more things from me. As Tony mentioned, the Lewisham project, that segues really nicely into just a quick bit of promotion about our Community COVID Champions programme. So we are working with Lewisham and running out a similar project in Birmingham. Thanks, Natalie, for whizzing the slides on. So we have launched our Community COVID Champions network. So if anybody you're working with wants to become a COVID champion, there's a web address that you can sign up for, oh my goodness, at the bottom of this slide here. And basically, COVID champions will get up-to-date, right, correct information from ourselves around COVID, around services, and the idea being that they can use it themselves or spread it to people that they live with, see in their communities, or have trusted relationships with. So making sure that the correct messaging gets to those that need it. So if you know of anybody or yourselves would like to sign up, we're welcoming as many community champions as possible across the whole community of networks, so we get the widest range of people possible. So I think that just moves us on to the last slide for today, which is just kind of the summary. So a big thank you to everybody who's come to listen today, and hopefully you've picked up some messages and some service tips and things that are available that you can share with people that you're working with, or your families and friends. And also lastly, or not lastly at all, but also a big thank you to the speakers today as well, and all those that contributed in the discussion at the end. Without you here, we can't give this level of information, and certainly from the public health perspective, we need to work with partners to make sure there is the best and most appropriate information available across Birmingham, and that we really are reaching those who need it with all the services that are on offer. So a big thank you to everybody for joining us today. On the slide, you'll just see the links to where you can download the handouts that I messaged at the beginning, and where you can book the webinars. Equally, if you have questions, there's the 2 email addresses, one for general and one for any COVID specific, more outbreak related questions. So I think that's all from us today. So a big thank you for listening. Thank you to those in my team who've organised the webinar today as well. And we will see you all, I think, well, a lot of you next week for, I think we've got physical activity up first next week. So thank you from me, and have a good afternoon, everybody. Bye.
Thanks for the invite. Thank you.
Welcome.
Thank you.
Thanks. Bye-bye.